So good morning, good afternoon, or good evening, depending from where you are joining us. Tonight, the IVPN NeuroPsychiatry, supported by Novartis, is organizing the second NeuroSTAT webinar, our one-of-a-kind learning experience. During this educational activity, you will learn at the same time about neurology from both the clinician and the biostatistician's perspectives. Our second NeuroSTAT webinar will discuss the long-term safety and efficacy of erenumab through real-world data and live case discussions, as well as the basics of statistics, which will help us as healthcare professionals to read and interpret real-world data. In fact, the clinical benefits of monoclonal antibodies targeting the calcitonin gene-related peptide, CGRP, receptor pathway have been demonstrated in multiple 12 to 24-week double-blind randomized clinical trials with significant reductions in migraine frequency and improved health-related quality of life. However, little is known about their long-term safety and efficacy. Before introducing our first speaker, I would like to thank Novartis for always supporting such innovative educational activities. Our first speaker for tonight is Dr. Rudy Nawar. Dr. Rudy obtained his fellowship in neurology from the University of Paris 7 in France in 2017. He has more than 5 years of experience in neurology in some of the most prominent healthcare institutions in France, Lebanon, and United Arab Emirates. Currently, he is a neurology specialist at the Reem Hospital in Abu Dhabi in the UAE. He is actively involved in the headache field and novel anti-migraine drug targets. Dr. Nawar, you are always the most welcome. You can start the presentation. The floor is yours.
Good evening, everybody. So thank you so much, Dr. Maya, for your introduction. It's always my pleasure to be speaker in our sessions, and I hope you're gonna like the presentation of tonight. So, everybody is hearing me?
Yeah, we are hearing you and your slides are looking perfect.
Okay, thank you so much. So I'm going to speak tonight about the long-term efficacy and safety of erenumab in migraine prevention. And as usual, I'm going to start my presentation by one case. Okay, so I will speak about a classical case because I'm going to keep Dr. Rami to speak about more complicated cases for tonight. So my case is a true case that came to my clinic. She's 21 years old lady, past medical history, depression, asthma, no past surgical history, no allergy, family history other than her mother. She has diabetes, no other diseases. She's still a student, she's single, and she complained of headache. When I asked her about her headache, she described her headache since 3 years, most of the time unilateral, pulsating in type, severe, 4 days per month. She denied any history of trauma, and her headache was always accompanied by photophobia, sonophobia, neck pain, and nausea. So at the same time, I asked her, what are you taking medication for your headache? So as she told me that before somebody prescribed for her Topamax, she reached 100 milligram once per day for, as they expected, it is migraine, and daily ibuprofen and paracetamol, even with taking Topamax. So when I ask her of other symptoms, and because my clinic is very busy for headache and migraine patients, she described to me this kind of pictures that sometimes in some attacks, before the headache, she described this kind of flu on the edges of the visual field plus colored lines. So when I asked her a little bit more about her depression, she told me that most of the time she complained of insomnia since 3 years. She sleeps maximum 4 hours per 24 hours. She's always complaining of overthinking, fatigue. She's demotivated, sometimes no appetite for food, and decreased attention. So when I examined my patient, nothing was really special. A physical exam was normal, general exam normal, neurological exam normal, and her blood pressure was 120/70, and somebody prescribed for her lab orders. So when I analyzed them, I saw that she presented a little bit a low ferritin, mild low ferritin for her age. So TSH was normal. Usually for my patients, I ask them to make something called headache diary. And it helps us too much to understand what patients exactly is complaining for. So this patient, I saw her in 2021. She consulted me on October. So when I saw her after that in January, so she told me, this is my headache diary. She complained 4 days to 5 days maximum of headache per month. So usually she brought for me, as most of the patients that complain of headache since many years, this MRI that I saw it. Usually, as you see, nothing really special for a patient of 21 years old. So I went from the supratentorial area to the infratentorial area. Nothing really is a secondary cause of her headache. So as any neurologist or doctor, usually I'm asking myself in front of the patient, what is my diagnosis? What test should I request? And how should I manage the case? Because finally the patient is coming to relieve the pain without maybe side effects or other adverse effect from medications. So as you see that most of the time when a patient is complaining of headache, unilateral throbbing, nausea, photophobia, like hypersensitivity to the light, to the sound. So most of the time we think about migraine, especially that her physical exam was normal and she's complaining of episodic attacks of headache. So usually why I thought about migraine in this case, because as you see that migraine usually is accompanied by nausea, visual disturbances, phonophobia, and photophobia. And always the patients are asking us, do you think, doctor, there is any genetic influence? There is any environmental triggers? Is it associated with substantial personal, economic, and social burden? So those are the questions of most of our patients. So as you see that migraine is the 5th leading cause of years lived with disability in MENA, it's present more in the young category of age. It's more common in women than men, and usually it's classified based on the number of attacks per month. So when we speak about less than 15 headaches day per month, usually we consider the patient most of the time as episodic migraine. When it's more than 15 days, it's more like a chronic migraine. So it's one of the most prevalent of all neurological disorders. I can really, by my experience, maybe 90% of my patients coming to my clinic are coming mainly for headache. Migraine or other than migraine, but it's one of the most common chief complaint from our patients. The prevalence is more than 10% of the global population. So as you see that if, for example, we have 8 billion people in the earth, so we can speak about at least 800 million people complaining of migraine. In the Arab countries recently, we were speaking about even a higher percentage of migraine patients that can reach sometimes 1/6%. As you see, migraine is not just headache, because most of the time the headache and migraine lead the patients to go many times to the ER, many sick leave, many medications, and the patient will cost more money to their insurances and to the government. Why I like too much this slide? Because mainly it's very important in migraine to understand that there is many phases. Usually when we speak about migraine, it's not only headache, because most of the time there is a phase before the headache that is described by the patients as fatigue, neck stiffness, food cravings, and repetitive yawnings. Even there is a phase similar after the headache. So the patient is not just complaining of headache and symptoms of migraine during the attacks, which last from 4 to 72 hours. No, sometimes it's even before and after by days by other symptoms. So why it's important? Because I want to know if I treat my patients and which medications can fit to this patient. So as you see that when I ask the patient, please note for me the days that you are complaining of other symptoms related to migraine and to headache. And as you see that the patient from the same 3 months, October, November, December, she described another numbers that 10, 8, or 14 days of bothering symptoms due to her migraine. So it changed too much, because if we speak just about headache days, we can speak about 4 days, but in general, the patient is bothered by 10 to 14 days per month. So as you see that, yes, migraine, there is a genetic component, there is environmental factors. How to diagnose migraine? Mainly when typical cases are presenting to our clinic, clinical history and examination can sometimes lead to understand that it's migraine. But usually when we have atypical symptoms or atypical physical exam, we should go for further investigation. So usually, as I said, that migraine is most of the time unilateral, but sometimes it's also bilateral, sometimes it's diffuse, sometimes it's atypical migraine. Most of the time it's unilateral, throbbing, worsened by movement, by exertion. Most of the time moderate to severe in intensity. Nausea, vomiting is most of the time reported by patients. Phonophobia, photophobia, also this is one of the symptoms that the patient is consulting our clinic. When we speak about aura, it's always 1/3 patients of migraine are complaining of aura. Aura, it's any neurological symptoms that is reversible, that sometimes is preceding the headache or coming with headache, or sometimes isolated without headache. Usually when we speak about aura, most of the time it's visual symptoms, but sometimes other than vision, we have sometimes numbness, tinglings, vertigo, dizziness, or weakness in some category of migraine, such as hemiplegic migraine. So usually the headache phase is lasting from 4 hours to 72 hours. But as I said before, that sometimes the symptoms are preceding the headache phase and post-headache phase. Most of the patients are asking us, what can trigger my migraine? So I like this slide to show you that most of the time stress is one of the most important factor triggering migraine attacks. And then we have sleeping and eating disorders, such as sometimes in fasting, we can trigger our migraine. Most of the time also sleeping disturbance can also trigger migraine. Some food such as spices and other cheese or dark chocolate can sometimes trigger migraine, and other triggers can sometimes described by our patients. As you see, sometimes we classify migraine based on the monthly attack migraine as intermediate frequency, high frequency, or chronic migraine based on the number of days of headache. The question is the following: when we treat migraine by preventive therapy or just acute therapy? So as you see that we can start preventive therapy when the patient is reporting more than 2 severe or disabling or 4 less disabling migraine attacks per month. Acute migraine treatment is ineffective or contraindicated when the patient is also complaining of medication overuse, headache, patient preference, and highly disabling migraine attacks such as hemiplegic migraine or migraine with brainstem aura. What kind of treatment do we have to treat our patients? Usually it's classified as acute treatment or preventive therapy. As acute therapy, as you know, triptans, NSAID, like analgesic, any analgesic that can work for migraine can help the patient. Most of the time, I'm avoiding all kinds of narcotics and all those that can make side effects to the patient. So I'm limiting myself most of the time to triptans, NSAID, and gepants. And for preventive therapy, we have the classical medications such as topiramate, amitriptyline, sometimes propranolol. And we have nowadays the new therapy, which is the CGRP monoclonal antibodies, that I will speak a little bit about them in our next slides. So what's CGRP? Most of the time our patients will ask us, what's this medication? Why there is injection for migraine, how it works? So as you see that the CGRP receptor is part of the calcitonin family of receptors, And in studies, it showed that it has a role, it's associated with migraine pathophysiology. That's why when we speak about blocking this receptor with any molecule such as erenumab, galcanezumab, or other medications, we have a rapid effect from the medications and persistence effect depending on the medications. So as you see, when we spoke about studies in erenumab, especially that we will speak tonight about erenumab, one of the most common medications nowadays for migraine. Usually it was studied in many trials. When we speak about STRIVE phase 3 trial, including the episodic migraine patients, as you see that the monthly attack migraine was decreased compared to the placebo in the two available doses, in 70 milligram and in 140 milligram. And in patients with chronic migraine, we had the same effect, that there is a huge difference between the placebo category of patients and patients that took 70 milligram or 140 milligram. Now, the other questions that some patients will ask is when the onset of efficacy. Some patients are considering that any medication for migraine should work from maybe the first minutes. I always tell the patients that in big studies, erenumab or Aimovig in the market, 70 or 140 milligrams showed effect within the first week after receiving the first injection. And this effect lasts for the other few weeks till around 23 to 26 days. This is what the half-life of the medication. So that's why the patient usually most of the time every month is coming to renew his medication. As you see also in chronic migraine, it showed also that from the first week, the 70 milligram and 140 milligram showed effect from the first week on patients complaining of migraine. The other question is long-term safety and sustained efficacy. As you see in the studies over 4.5 years, erenumab had persistent effect on migraine attacks. And as you see that more the patients took doses, it means during the first few months till like 4 years, more the effect was more powerful in those patients by reducing more the baseline of their monthly migraine attacks. And most of the time I'm asking my patients, what exactly do you need from the medication? Some patients, their concern is to avoid side effects. They don't want to take any medication that can cause for them side effects. So when we compare erenumab to placebo, there is no major side effects in both categories. And most of the time, by my experience, like over than maybe 700 or 800 injections of erenumab, honestly, I didn't get too much complications other than maybe 2 patients complained of constipation from the first dose. Then it worked very well from the second dose. And till now, those patients are continuing the erenumab. I can say that most of my patients didn't present the high blood pressure that was reported recently, but in general, when I give erenumab, I always observe the patients from the vital signs effect, blood pressure, and I'm always asking the patient about constipation because it was reported in big studies. So as you see that erenumab also demonstrated sustained efficacy in the open label treatment phase of the chronic migraine, same as the episodic migraine. Over 1 year, the effect was sustained and it was even more powerful during the following few months. So maybe if we will ask ourselves, why not giving the classical treatments such as maybe topiramate or amitriptyline, propranolol, before they were giving depakine, but nowadays, especially with the side effects of depakine and other medications, we are avoiding from time to time those medications for their side effects. As you see that we had recently one trial that was published. It's a German trial called Hermes study that compared erenumab to topiramate. So as you see, it was done in Germany. They studied the effect of erenumab and topiramate. It was done in 82 sites in Germany. They included episodic and chronic patients. And it was conducted recently during the last 2-3 years. And the primary objective was treatment discontinuation due to the adverse effect. So their point of view is to see which medication will present more side effects and what patients, or what's the percentage of patients that will stop the medication due to the side effects, comparing the two categories of patients. So the secondary objective is for sure the efficacy of the treatments, both treatments, and at least 50% reduction of monthly attack migraine over the last 3 months of receiving the two trial medication. So the exploratory objectives were reduction of monthly attack migraine over the last 3 months, impact on functional impairment measured by one score called HIT6, and the impact of quality of life measured by SF36V2. As you see, it was double-blinded treatment. They compared erinumab 70 or 140 milligram monthly subcutaneously to topiramate. And then if I go directly to the result and how they did the test, usually for sure women will be more than men, because in general, the migraine attacks women more than men. So that's why in the study, female patients were more than male patients. They analyzed around the same number, 389 patients in the placebo group and in the treatment group. Then they choose in erinumab and topiramate the same category of patients, around the same age, same sex, same race, and the body mass index. And then they analyze their monthly migraine attacks and their acute headache medication use, and the prior treatment failure status of each patient. So they analyzed the patients that were naive. They didn't take in their life any preventive therapy, 1 treatment before and it was failed, 2 treatments or 3 treatment failed. And then as you see that they categorized the patient based on their monthly attack migraine and then the prior prophylactic treatment, naive, 1, 2, or 3 medications. So, and then we were surprised by the results of the study that showed that almost 4 times more patients discontinued the treatment of topiramate due to the adverse effect compared to the erinumab. And then where patients were almost 3 times more likely to reduce their monthly attack migraine by receiving erinumab versus topiramate group. Then, as you see that one of also the endpoint was the headache impact test that showed that patients receiving erinumab were more comfortable than the group of people that received topiramate in the 2 categories. And finally, patients reported a greater improvement in the quality of life in the erinumab group compared to topiramate. Then here, the most important point is the adverse effect of the 2 medications. And as you see that, as I told you in the result, that the patients stop more topiramate for their side effects compared to erinumab. And this slide showed that even the severe adverse effect were comparable, 0.3% in erinumab versus 0.5% in topiramate. So the 2 groups of people didn't complain of any severe adverse effect, but the mild adverse effect that lead the patients to stop the medication were more in the topiramate group compared to the erinumab group. And then erinumab, as all the trials or studies showed, that it has a very good safety profile. No new safety events were observed within the Hermes study. And the study concluded that the treatment with erinumab demonstrated a superior tolerability for erinumab compared to topiramate. And usually it was safe. It presented a more important quality of life, better quality of life in the group of people that received erinumab compared to topiramate. And then I would like to say thank you for the audience to watch our presentation. And as I can say by my experience, that most of the patients that received erenumab in my clinic, really we reach more than 50% improvement. I have around like 30% of the patients even achieved 100% response from the first injection. As severe adverse effect, I didn't encounter any severe adverse effect over the 800 injections. And usually it's a safe medication, and patients are preferring to take sometimes one injection than taking everyday tabs for their migraine. So thank you so much. And I'm ready for any question.
Thank you, Dr. Rudy, for an excellent presentation, very comprehensive one. So yes, actually, we have some questions for you. So the first question, can children experience migraine?
Yeah, so the children can experience migraine for sure. And what's the strange in their migraine that most of the time it's atypical. So because I'm not seeing pediatric patients in general less than 13 years, but I have some from time to time, some kids from my patients, migrainists that are presenting also for the same symptoms. And in kids, usually in general, their migraine is atypical. It means sometimes it presents just by dizziness, sometimes by fatigue. For example, I saw recently a kid of 7 years. His migraine is more like hypersomnolence. It means when the patient has migraine, he likes to sleep for the next day. And for sure, it's always a challenging cases for us because most of the time we are limited by medication. As you know that erenumab, maybe I didn't mention in my slides, but erenumab or Aimovig is not like unsafe for pediatric category of patients, but it's not studied for the ethical reasons. And that's why I believe in the future, maybe more pediatric patients will be involved with those medication, because till now we didn't see really severe adverse effect. And those kids are really affected by their migraine, especially in their school, especially in their concentration. And let's say 2 or 3 days per month of migraine for a kid, it's catastrophic. So yes, they can encounter migraine attacks.
And what is the best or optimal treatment, or what is the standard treatment for children with migraine?
Yeah, this is always one of the most, let's say, difficult questions. Even I remember maybe last week when we also presented, everybody was also asking that what we can give a kid the best treatment. Most of the time, we don't have exactly one treatment that it fits to everybody. But most of the time in my practice, I avoid, for example, I will not give a kid, let's say, amitriptyline, SSRI, or TCA for their migraine. I'm avoiding as much as possible any medication that can lead to side effects. Sometimes a little bit of magnesium, low dose, can sometimes work in migraine patients, especially when they are young and complaining of migraine. If it's episodic, I advise the parents most of the time to take like just paracetamol or NSAID very low dose. It's always depending on each patient. And as you know that sometimes patients, like even they are pediatric, but they have, for example, 80 kilos, they look really mature. So sometimes it's very challenging for us. And sometimes they come just to receive erenumab. So my answer, no, I cannot, because for ethical reason. So it's always difficult to choose one treatment for all the pediatric category.
Yeah, I agree. So, doctor, another question. I actually have 3 questions, all asking about the safety of erenumab in pregnancy. So, the attendees are saying that always the treatment of migraine in pregnancy is very challenging. So, are anti-CGRP in general and erenumab in particular safe for use in pregnancy? Do you have such data?
Till now, the erenumab is not allowed to prescribe to any pregnant woman. So that's why the challenging here is when we want to prescribe erenumab to a patient young that maybe there is a plan for pregnancy, I'm always avoiding to give erenumab if the women are planning in the future to have directly kids, maybe after 1 or 2 months. By my experience, what I'm doing with some of my patients, 3 or 4 patients, I advise them to take their erenumab injection after their period, because it's not about safety. It's about that it's not studied. Until now, we are not allowed to give a pregnant woman any anti-CGRP monoclonal antibodies, even gepants. And both sides, it's not allowed. And in pregnant women, even we avoid, as you know, even the classical treatments such as topiramate, amitriptyline, all of those, most of the time, I prefer to avoid them in this category of patients. And it's very challenging. So
Another question, hypertension, is it a contraindication for the use of erinumab?
If it's a high blood pressure, usually when patient is presenting to my clinic with high blood pressure, we have most of the time to think about secondary cause. And that's why in those category of patients, like atypical scenarios, I prefer to do investigation before going directly to the anti-CGRP. It's true that sometimes pain can increase the blood pressure, but usually if the patient is already high blood pressure, he has hypertension, uncontrolled, I prefer to go for imaging, checking that it's not something like in the brain as secondary cause. If the patient, let's say it's a typical migraine, but he's presenting high blood pressure. If his blood pressure, let's say 140, 150, and he's like, we don't have other choice than giving erinumab, I'm following up those patients by their blood pressure. In my register of patients, that may be around like, I can say like 70 patients took erinumab and they have hypertension. I saw even a decrease of blood pressure. Why? Because patients, the second, like, and during the follow-up visits, they were very comfortable of their pain. And pain was by itself one of the cause of their high blood pressure. But for our audience, they should follow up the patients that are receiving erinumab by their blood pressure. If the blood pressure is very high, it's better to avoid any medication that can trigger more their high blood pressure.
Thank you. Another question, how long does it take for erinumab to be cleared from the body? So the half-life.
Yes. So usually the half-life is usually when I prescribe erinumab, I'm telling the patient that usually it lasts till like 23 to 26 days. It's different than, for example, the Gepen, that usually the half-life is 11 hours. So for the anti-CGRP, it's more about days. It means it can last sometimes till 23 to 25 days. And here we have to think about the patients that wants to be pregnant, because it's very important question for those patients.
Yeah. Another question, is erinumab can be used in patients with stroke who have concomitant stroke or history of stroke and migraine?
Very interesting question, because when I was working mainly in stroke unit, we had many patients of stroke presented also presenting a headache. So here it's very important question. Is it clinically a migraine, or is it a secondary cause of stroke, headache? The pathophysiology is completely different. So when we speak about headache post-stroke ischemic or hemorrhagic, the headache is secondary to their stroke. So it's better to treat just acutely the pain than giving an anti-CGRP. If the patient had stroke, but at the same time, he's very well controlled, he's very stable, no comorbidities, and the migraine is very typical, why not? They can benefit from this medication. At the same time, they need a good follow-up, because those patients already, they are like unstable compared to a patient that has no stroke.
Another question, is erinumab safe to be used during lactation?
This is always like pregnancy question. So
yeah.
When we ask more the expert, they don't have a problem sometimes to give erinumab during lactation. But personally, I prefer sometimes to avoid any medication during pregnancy or lactation, just in the aim to wait other studies that confirm to us that it's so safe. Because, you know, as doctor, any complications from the patients, they will blame the doctor that maybe this medication caused any adverse effect. So from my point of view, it's better to wait a little bit. So before giving any patients during, like, especially the first period erinumab, till we have maybe in the next few years any study about the pregnancy category of patient, the pregnant woman and the lactation period.
I still have 3 questions. Please, I would like to ask you to answer them quickly, just not to delay further, Dr. Rami.
Sure.
So is it safe to use erinumab in patient with history of MI, of myocardial infarction?
So it's same as a stroke.
Stroke.
Usually, yeah, it's same as stroke. I prefer to avoid, especially if they are really unstable and high blood pressure.
For
And
how
so,
long? Okay. For how long the patient can use erinumab to treatment? So the duration of therapy.
yeah, before August 2022, I was telling my patients that you should take 9 months to 1 year. Recently, in August 2022, with the new European guidelines, they allowed us to give erinumab for more, even, it means even 4 years. I have patients that already since 2 years are taking erinumab, and very safe. They are very satisfied. They tried to stop, but the migraine came back, so they prefer to continue. And with the new guideline, I'm more confident to give this medication for more long time.
What about the role of ketogenic diet for migraine control?
Till now, as you know, that some diets can increase migraine. They can trigger migraine. And some treatment or diets can sometimes even be beneficial to the patients. From my point of view, I never honestly prescribe any kind of diet to the patients, but the most important that I'm telling my patients that avoid all kind of food that can trigger migraine, such as spices, some kind of cheese, dark chocolate. This is the main maybe food that can trigger migraine.
How do you compare erinumab to rimegepant?
Rimegepant in general, it's more indicated for acute episodic migraine. It can be prescribed every 2 days as preventive therapy. When I decide to give more rimegepant as preventive than erinumab is when the patient is really phobic from the needle. The preference of the patients, he wants completely PO medications. And usually the gepant, especially rimegepant, they last mainly 11 hours half time. It means 2 days, 48 hours. When I tell the patient rimegepant, it lasts 2 days. Erinumab, it can last for 25 days, 26 days. So this is the difference between the two.
The final question, I promise you. So, but I'm over flooded with question. So, how do you differentiate the diagnosis of trigeminal neuralgia from migraine?
Yes, so here the clinical and the history of the patient. As you know, that trigeminal neuralgia is a pain, very severe pain in the nerve 5 territory that is very, very severe on one side, and it can take like one branch of the nerve 5 or many. It lasts for a few seconds, and sometimes it's repetitive during the day. The treatment is completely different. Migraine is more a unilateral headache that lasts from 4 hours till 72 hours, even sometimes more. The symptoms of migraine, photophobia, sonophobia, is less likely to see them in trigeminal neuralgia. And the category of age in migraine is more younger than trigeminal neuralgia. Trigeminal is more in the 50s, migraine is more in the 20s.
So those were the questions. Thank you, Dr. Rudy, for taking all our audience questions, and thank you for accepting our invitation. It's always a pleasure to have you with us. And I will move to our second speaker for tonight. So who is Dr. Rami Al-Attat. So, and who is joining us from Kuwait. Dr. Al-Attat is a professor of neurology at the Lebanese University in Beirut, Lebanon. And after more than 11 years of experience as a neurologist in many reputable Lebanese hospitals, he moved to Kuwait, and he is currently a consultant neurologist at the new NeuroSTAT hospital. Dr. Rami holds a certification in neurophysiology and in botulinum toxin injections. He is an active researcher and has many publications in the field of neurology. Dr. Rami will interactively discuss with you 4 migraine cases from his clinical practice. So I would like to invite you and to encourage you to benefit from this session and to interactively answer to the cases questions. Welcome, Dr. Rami, and the floor is yours.
Thank you, Maya, for your kind introduction. And thanks for Dr. Rodi for the fruitful presentation. And hello for everyone. Good evening. Now I'm going to present 3 to 4 cases. They are real cases from my outpatient clinic. And each of these cases will present different aspects of challenges that the clinician may face and may need to treat migraine. So I ask you kindly to make the session interactive, just to answer the poll and also to analyze the cases, to participate and to make it fruitful meeting. Hoping I will finish at time because we have 4 cases. So this is my disclosures without any interest others. So there are several questions during our practice in our clinic. And these questions, they are mostly asked by our patients. Until now, we are now in 2023, until now we hear from patients such questions. Is there any medication for migraine? Because most of the patients, or a part, let's say, they don't know that migraine can be controlled. Is migraine treatable? So these questions always we face it in our clinic. Or there's some question, I don't like to use medicine. It is very important because patients, they always asking, is there any way to decrease or reduce the pain of migraine without using medicine? Because they speak about the side effects of the medications, and we have to take care and we have to take in consideration these questions. I try to handle the pain without using medications. I can just power through the symptoms. This usually, when you ask patients why you are asking these questions or why do you have these questions, mostly because they are afraid of taking the medication because of the side effects. And what are the side effects? It is very important because most of the traditional or classical medications that we use they have a side effects. I am worried of the side effects. You can hear these questions too much. And from our aspect, what to treat and why to treat, what is the importance of treatment? Always I have to explain, and I advise you all, when you want to explain for the patients, just you have to tell them that we are reducing the frequency, the attacks, and the intensity of the pain. Maybe we cannot abort it completely 100%. Now we have many patients, they are free of pain. We have reaching 90-95% of a very good outcome, but actually we cannot say it is 100% abortive, okay? For that reason, when I want to explain for my patients about the treatment that I'm going to give, I always explaining that we need time, first of all. Don't come in the second or the third day asking me that I'm still in pain, because medications, they need time. It needs time to resolve the pain. Plus, we are working on the frequency, intensity, and the attacks. So patients want to live their healthy life, well life with their families, because migraine may lead them not to go to the social life, they avoid to be gathering with families. So untreated migraine can potentially make migraine worse. This is very important. So we have to treat migraine because to avoid any worsening of the disease. Frequent migraine also cause more frequent headaches. As the sooner the migraine is treated, the better the outcome. Are the side effects worse than the migraine? This question is very important. I want to insist about it. When the patients come to you, as we are now talking about clinical cases, we are sharing our practical cases together. So you will find these questions and you will find that the patient say, I'm afraid of the side effect of the medication. So you have to answer, or you have to ask your patient from your from your part, are the side effects worse than the migraine? So you have to clear for them properly about the side effects. Just explain, just make them relief, give them the power to take the medication, and just to be calm, not to be afraid of the side effects of the medication. Just I always say for them, we can control the side effects, don't worry. Side effects, it is still less and better from the migraine headaches that you have. So now I will go further in the first case. This is a direct case. It is a 41-year-old male active employee. I remember he was a manager. He was complaining of 13 years history of headache, with mainly starting from his occipital area of his head and then become to the whole cranium that increase with head movement on exposure to sun and by climbing stairs. It means that by making any exertions. So intensity, it is very important to know the intensity. Is it mild, moderate to severe? Because intensity, it may lead us to a very good decision for the treatment. Duration, it was from hours up to 2 days. Attacks, 6 to 7 attacks per month. In this one, I want just you to know that the attacks, it's different from the duration. Maybe the patient will have 2 to 3 or 4 attacks, but with 1 day or 2 days. So we have always to see the attacks, to ask about the attacks and the duration. So associated with photophobia, triggering factors, it was work and exercise. He used several medications such as non-steroid, the triptans, but with mild relieving effect. And he did already, when he came, he was already done, it's done CT brain, MRI brain, and the blood test. It was done 1 year ago. So I want to ask you, would you do for this patient or for these cases, MRI, brain, blood test, or CT and imaging? Please answer the poll.
I'll be stopping the poll.
Okay. Okay, there are 2 different answers, like 80% yes, and some of them 20 no. Actually, in this case, both answers, they are right, we can say. Why? Usually, just to know one thing, when a patient presents with the same type headache, with the same frequency, the same intensity, usually we don't do or ask for imaging, unless if there is a changes in the frequency, attacks, or the type of the headache. But also, it is not wrong if I will do it. So I can do it, and I cannot. I can order it, or if I want, I will not order it. But when we want always to ask for imaging studies for the migraine patient, just we have to ask about the type of the headache, if there is any changes. Would you consider this patient as a good candidate for prophylactic treatment? Please answer.
I'm stopping the poll now.
Okay, also 84% of the answers yes, and 16% no. Here we have to discuss it a little. that if we want to start preventive or prophylactic treatment, we have several prophylactic. We have several options: the traditional or the classical, like amitriptyline. We have beta blockers. We have valproic acid, topiramate, and others. And the new medications that we can know it, which are the anti-CGPR medications, Japan's medications, Botox injections. So prophylactic treatment, usually we offer it when there is attacks significantly interfere with patients' daily life. And if there is a frequent attacks, more than 4 days per month. And if there is any contraindications to the medications, to the medications for acute pain or failure of the acute treatment. So in this patient, surely I will go for prophylactic treatment. So what prophylactic treatment would be recommended for this patient? So please, can we choose beta blocker, topiramate, amitriptyline, valproic acid, or CGRP? So we have here different options. There are 5 medications listed here in order to answer and to know what medications we are going to prescribe.
I'm stopping the poll now.
Okay, here the majority started, they want to start beta blocker. Second, CGRP, we have amitriptyline, different questions, and also valproic acid and topiramate. Okay, so let's discuss about this treatment. Usually when I want to start my the medication or to give the prescription for my patient, so I have always to take the comorbidities of the patient. It is very important. I have to discuss the side effect of this medication, and individually we can give and prescribe for our patients. So if we can see here the beta blocker, it is an effective medication for migraine type headache, but usually we avoid it for patients with asthma or patients that they have low blood pressure, and usually I always also avoid it in elderly patients just because you know, it will decrease the erectile dysfunction. It will lead to erectile dysfunction. Also here, the second one is topiramate. Topiramate, it is very effective also as a prophylactic treatment. And the side effects of the topiramate is to decrease the weight, which females usually, they love topiramate to decrease their weight, to control their weight. And also the bad thing is that in renal colic, we cannot prescribe it. So just pay attention for this. And also topiramate side effect may cause tingling sensation in the peripheral limbs and the fingers of the hand. It is for that reason, I always advise some to take like some rich food with potassium, like potato or banana, when they want to take topiramate. Amitriptyline, it is one of the very, very good medication. I love this medication because it is very effective, but it induces sleeping. For that reason, I usually avoid it in patients who drive for long distance and for patients that they want to get up early. Plus amitriptyline, it will lead or it causes to weight gain. So females, they don't like it. And also, you know, as antitricyclic antidepressant, it may cause or may have some mood changes. Valproic acid is good also, but I always avoid it in females. And we have the CGRP inhibitors. CGRP inhibitors, they are very effective medication. We can prescribe it freely for such patients. So according to the answer, we can choose any one of these medications, but we have to take in consideration the side effect of each of this medication. So I started Aimovig. Why I have started Aimovig for this patient? Because when I discuss the case with the patient, it is not wrong to start amitriptyline, not wrong to start topiramate, because he has no comorbidities for such medication. But as he is a manager, he works around 16 hours or 12, more than 14 to 16 hours per day. He has a very hard worker, he drives a lot. So he wanted something not to have or to cause for him side effects. So for that reason, I discussed with him this issue and we started Aimovig. After 1 month, he became with improving of his symptoms, reduction in intensity and the frequency. And after 4 months, the pain reduced around 90%. He had a better quality of life, plans, and personality looking. Actually, I have a very good practice with Aimovig and experience since I started in the studies and the compassionate use in Lebanon since maybe as I think in 2017. So we have many cases on Aimovig, and I see that the side effect and the adverse effect of this medication is very rare, with a few patients that complained of like only constipation, but there is no major side effect of this medication. The second case here, it is a female police officer. She's 28-year-old. She was complaining of migraine headache since age of 18. She complained of unilateral alternating from side to other increases at the beginning of each menstrual cycle. So it is a migraine, but it is exacerbated during the menstrual cycle. 5 years ago, after her childbirth, the headache increased severely in intensity and the frequency, with symptoms of unpleasant sensation in her stomach, photophobia, and also this may last up to 3 days, making her absent from working, affecting her daily living. This I want just to show you that and to explain that patients with migraine, it is they are not only complaining of headache. There's one slide that Dr. Rudy presented about the prodrome, about the phases of migraine, that patients not only headaches they complain, but even from other complaints, which are the aura or without aura, like unpleasant sensation in his body, unpleasant sensation in the stomach, dizziness, photophobia, and may last even 30 minutes before or after the headache onset. She is overweight. Just take into consideration that she is overweight. She had 2 episodes of renal colic 2 years ago, and she received botulinum toxin injection 4 weeks ago. 4 weeks ago, yes, for cosmetic purposes. So it is very important to know these things: triggering factor, TV, noise, hot weather, and any exertional exercise. So she was started on a propranolol 40 milligram BID, but episode of syncope and pre-syncope happened with a low blood pressure. She was given triptan for acute pain. Brain MRI was normal, and neurologic exam was stable. So what medication would you prescribe in this case, please? So are you willing to give beta blocker, amitriptyline, valproic acid, CGRP inhibitor, monoclonal antibodies, or botulinum toxin? So please answer this. It is very interesting case, because from this case we can know how to approach our treatment.
Okay, I'm stopping the poll now.
So here it is written, the answer was such as beta blocker 27%, amitriptyline also 22%, valproic acid, CGRP inhibitor 29%, and botulinum toxin. Okay. So different questions from our colleagues. So I will explain this. First of all, beta blocker, I will not. Why? Because she already, if you remember the slide before, she was on propranolol and she had several episodes of her pre-syncope with a low blood pressure. Amitriptyline, one of the side effects and unpleasant effect for the females is gait waning. So this patient, she is overweight according to the body mass index, and she will be not happy to give her amitriptyline, I'm sure. And also, just take in consideration, she is an officer, police officer. She must get up early every day around 6:30. So I will not also to induce for her sleeping. Valproic acid, usually I avoid it in females because, you know, it may cause some cases of ovarian cysts. And the CGRP inhibitor, I will talk about it. Botulinum toxins. What about botulinum toxins? It is very important to know that this patient, according to this patient, she received 4 weeks ago Botox injection for the face, facial Botox injection for cosmetic. Botulinum toxin, it is one of the very good medications that we can use it for migraine, for chronic. First of all, botulinum toxin, it was approved as a chronic migraine. And by definition, chronic migraine, it is more than 15 days of migraine headache per month. But after, also then was approved to be given for episodic migraine. But this patient, just to take in consideration, when she received the Botox 4 weeks ago, so we have to wait around 3 months in order to give another doses. Why? Because botulinum toxins, this medication, it will make an antibody against this medication. So if I will give botulinum toxin, maybe it will not be effective, as she already, the antibodies already, they are found in her body. So CGRP inhibitors, it is one of the very good medications. And when, if I want to ask when to start giving monoclonal antibodies targeting the CGRP pathway to reduce the migraine. Even now, monoclonal antibodies, which are the CGRP inhibitors, they can be given as a first line for migraine headache. So let's continue now. I hope that it is a fruitful cases for you. So why to prescribe anti-CGRP or the CGRP inhibitor? Why to describe them? Is it due to high efficacy, the less side effect, mode of administration, or the socio-economic reasons? Why we can present or to prescribe this medication?
I'm stopping the poll now.
For high efficacy, here we have 50% the answer, less side effects 38%, mode of administration, and socioeconomic reason. Okay, always when we want to present or to prescribe and to talk about the effectiveness of ironumab on migraine factors. First of all, what these are factors? It reduces the pain intensity according to the studies that we already heard. We have reduced the attack duration. Also, it have a less side effect on the patients. It improves the response for acute pain, and also it reduces the aura intensity and disability with a reduced aura duration. And less, as we said, the socioeconomic reason here, all the studies show that the painkillers or the acute treatment by time on the long run, it will cost more on the for the economy. It will be like like more difficult. Why? Because patient in this case, they will pay more money, they will be absent from their work and so on. So anti-CGRP, they are very good with a high efficacious medication. And as I said, according to the AHS, American Head Society, we can start as soon as possible with such medications. So patient was started on Aimovig after 2 months, well controlled, and she was very satisfied. Case 3. This is a 56-year-old female known for chronic migraine, being treated for years with multiple consultations. You know, patients with migraine and neurologists, they try to consult many of the neurologists and even family medicine. So she seeked many consultations, traveled for many countries seeking migraine treatment. She complained of 2 types of headache. One of them was explained as a top of her occipital area, radiating to the frontal, and the second involves her back of the head and neck. Treated by non-steroid inflammatory medication, acetaminophen, 8 to 12 tablets per day, high dose. Tried valproic acid, topiramate, triptan. She used a lot of medications to reduce the pain, also used to receive IV painkiller in the ER every 4 to 5 days, as she mentioned. Her MRI brain was normal and the neuro exam was normal. So what do you think about the diagnosis of this patient? Do you think, is it migraine? Is it a cluster headache? Is it a tension headache? Medication overuse headache or mixed headache?
I'm stopping the poll.
Here, yes, most of the answers, 35% is migraine. Second, medication overuse, also mixed headache, and less cluster and tension. Very good answers. Here, what we have to discuss is the mixed headache. This case, it is a case of mixed headache. Mixed headache of both of migraine and medication overuse headache. MOH, medication overuse headache, it is very important to know because it is very challenging for us. And really, according to our practice, according to our experience, it is one of the devastating cases that we deal with it, because it's very hard to control the pain. And even the patients usually they come in a severe pain due to high and very overuse of the non-steroid anti-inflammatory medication, acetaminophen, and many other analgesics. So this patient, she has migraine. She has migraine with a medication overuse because she was not on prophylactic. She was only taking for the acute attacks pain, but without a good and appropriate treatment. So this led to a medication overuse headache. So medication to be given. What do you think about this question? Is it a combination of prophylactic medication? Do we have to give steroids, botulinum toxin, no change in her current medication, or the CGRP inhibitor? What do you think about this?
I'm stopping the poll.
So here it is written combination prophylactic medication, steroids, botulinum toxin, no change in her current medication. So most of this of the questions or the answers, it is combination of prophylactic medication. And then CGRP and less steroid and no change in her current medication. Actually, This patient, as she was diagnosed for MOH, medication overuse headache. So first of all, I have to treat the medication overuse headache, which is treated and be controlled only by steroids. So admit the patient to the hospital and give around 5 days of steroid, which is a detox. We are giving detox for the patient to reduce the pain. After that, we'll see, other medication. So common questions, when to start CGRP? We start CGRP inhibitors as soon as a patient needs a prophylaxis in order to avoid side effects in some patients. And according to the guidelines, European guidelines, we can start as a first time. When to stop? This question is very important. When to stop monoclonal antibodies? All the studies now, when we started to prescribe monoclonal antibodies, leronlimab, we started for 6 months. After that, new studies showed it is good for 9 months and even for 12 months. And the latest, it is up to 5 years. And Dr. Rudy showed that it can be to 4 years, but exactly we have many studies that showed we can use it up to 5 years. And when to stop? Usually I stop the medication, the CGRP inhibitor, after 12 months if the patient is stable, so I can stop it. I will stop it and then I will follow up the patient. If the migraine attacks reappears for him and reoccurs for him, so I can start also a new prescription for the same leronlimab and to continue. And when to continue, as long as the patient is feeling good, so we can continue. Is there any side effects? Actually, the study shows that majority of them, they have only constipation, but very low percentage. The last case, it is case 4. In this case, I have a message I want to send it to you and to tell you about it. This patient, she's a 29-year-old, which is evaluated for severe migraine with typical aura and right-sided sensory symptoms that occurred 1 day prior to presentation. This is the presentation to my clinic. So migraine was diagnosed at age of 18 years, which is often preceded by 45 minutes of visual loss, which is only described as losing half of my sight, she said, is only associated with onset of menses, involve hemicranial throbbing pain, associated with nausea and vomiting, and last up to 90 minutes if treated and 24 hours if untreated. So it is a migraine with typical aura. Just pay attention that the aura here, it even exists as a losing half of my sight as explained by the patient. Also, here the migraine was again preceded by typical visual loss and 40 minutes later by numbness and paresthesia in the right upper extremity, starting in her hand and migrating toward her forearm. That can be also affect the right tongue, the throat sensation, and lasted up to 50 minutes and then resolved completely. So there is an aura, there is some somatic or some unpleasant sensations, and some patients really they come and they say I am feeling unpleasant sensations that I cannot explain it. We can hear this. The medications are rizatriptan and a combined estrogen, progesterone oral contraceptive, which is initiated 3 months ago. Just take this in consideration, estrogen, progesterone. On physical examination, blood pressure plus pulse rate, neuro exam, all was fine. History, it was a renal colic and MRI and allergic seasonal asthma, and the MRI was good. So which of the following is the most appropriate next step in this management? So please, do we have to administer aspirin? Do we have to give topiramate, discontinue oral contraceptive, or discontinue rizatriptan? Please answer.
I'm stopping the poll now.
So here, the majority of the answers, it is discontinue combined oral contraceptives. Great, very great answers. And some of them, they answered aspirin and others. So why do we have to discontinue combined oral contraceptives? Here we have several studies shows that the patients with migraine with aura, they have the tendency for a cerebrovascular event with contraceptive, with combined contraceptive medication, estrogen and progesterone. Even for women, it is higher, the risk is higher than that with hypertension. So patient with migraine with aura, they are at a high risk for cerebrovascular event if they are using a combined contraceptive. They can use progesterone. This now we have also the pills of only progesterone or the intrauterine device. It is a new, also new, newly. It is only initiated from progesterone. For that reason, we have to discontinue, and that's what I did. I discontinued for her the combined contraceptive. Do we have to administer daily aspirin? No, why? Because these symptoms, they are related to the aura. It is not neurological or cerebrovascular disorder that is causing the weakness and the unpleasant sensation of her extremities. And also there is no evidence of vascular disease in the brain, which is done. MRI showed a normal value. So no need for aspirin. Topiramate, surely no, because she has a renal colic, history of renal colic, so I will not give her topiramate. Do I have to discontinue rizatriptan? It is a triptan for acute treatment, and it is fine. She was, according to the case, she was well, feeling well on this rizatriptan. So I kept her on rizatriptan, and I asked her to stop the contraceptives. After 3 months, she then presented complaining of the migraine attacks, which is exceeded more than 10 days per month, despite of the rizatriptan treatment and non-steroid. So headache started to bother her in her daily activity. So what do you suggest for this patient? So it was an episodic migraine and then become a chronic migraine. Any suggestion for treatment? Do we give amitriptyline, topiramate, propranolol, triptan, or erenumab? Please answer. This is, I think it is the last question.
I'm stopping the poll now.
Okay, the majority, it is erenumab. That's what happened. Yes, usually, not usually, but she was started on erenumab as a prophylactic preventive treatment for migraine attacks. Avoided topiramate, avoided amitriptyline due to the side effects, and even triptan. She was already on triptan, rizatriptan, but for that reason, we started for her erenumab. So she was happy in this medication. So target of treatment is to completely relieve the pain optimally in 2 hours or less. This is the message. Relieve associated symptoms, restoration of normal function, minimize the disability, prevent headache recurrence, avoid adverse drug effect, treatment of comorbid conditions. And now, as we have many options, we have the traditional options, classical options. Also, we have the monoclonal antibodies, which are the anti-CGRP, like erenumab, eptinezumab, galactinezumab, and eptinezumab. We have also we have the Botox. We have the Gepant's group, like remigiptan, zavegeptan. So we have many options, plus the Ditan, also we have it. So when you want to choose any of these medications, just take in consideration these points that is written here on this slide and take in consideration the mode of action, how to give the patient, and the side effect of each medication individually. And thank you for your time. I think I finished at time. Yes, it's good.
Thank you, Dr. Rami, for this very enriching session. So I have some questions for you, but I wish you can answer us very quickly to take as much as possible of question. So the first question, can we use erinumab as a first-line treatment?
Yes, there is a question was, or there is a guidelines in European Academy for Neurology. When should treatment with monoclonal antibodies targeting the CGRP pathway to be indicated? We can start as a first line. We can start as a first line.
Another question, do we decrease the dose of CGRP treatment after menopause for a female patient with migraine who was already using this anti-CGRP before her menopause? So if she became menopause, do we discontinue the treatment or do we decrease the dose?
No, we can give her the same treatment, pre or post-menopause, no problem. We can give it for her.
Okay. Amitriptyline, does it increase or decrease the weight?
Amitriptyline tricyclic antidepressant, yes. One of the side effects of amitriptyline is to increase, it's increasing in weight gain. For that reason, females, they don't like it.
Another question, what are the major side effects of topiramate?
The major side effect of topiramate, we have to avoid it in the renal colic, first of all, renal colic, because it induces renal colic formation. So, and plus one, as mentioned before, it induces tingling sensation in the extremities, in the fingers. For that reason, give any diet rich with potassium for this patient, like banana or potato. Okay. And also, yes.
Sorry. Continue.
Okay. Also, some patients, they may have a mood changes and mood wavy, feel unpleasant sensation due to topiramate.
Another question, anti-CGRP might be more expensive than botulinum toxin, and this might be an issue for insurance or even for individual patients to afford their cost. So do you think that we can compare the cost effectiveness of Botox compared to anti-CGRPs?
Actually, you know that erinumab, we can prescribe it on a monthly basis. It is indicated between 26 to 28 days we have to give the injection, but most of the insurance companies here, they are covering once per month. So it will last up to 12 or 15 months. We can keep the patient on this medication. The Botox injection, usually we can give the first dose, and after 3 months we can repeat if the patient is still complaining of the headache, or even every 3 months up to 6 or even 1 year we can repeat it. Here's a cost effective if the patient will respond at the first dose of Botox. Maybe yes, it is a cost effective, but we don't know clearly if he's going to be cured in first dose or not. For that reason, the cost effective in this case for 1 year, maybe it is less for erinumab.
And probably for Botox, it's more difficult to get insurance approval. So anti-CGRP and erinumab is more easily approved, and we can get insurance approval on it and convince the insurance company more easily than botulinum toxin, which is usually reserved as last line or last resort in migraine, right?
Maya, till now, according to our experience, no insurance in Lebanon or in Kuwait, according to my experience, approving. They are approving Botox for spasticity, yes. Yeah. For dystonia, yes. But for migraine headache, till now, we don't have.
Yeah, it's very difficult to get approved. Yes. Yeah, I totally agree. Emovic, so erinumab 70 versus 140 milligram, which dose to use?
Usually the indication is 70 milligram, but in case the studies of erinumab shows that in case of severe migraine attack, we can load the patient with 140 milligram once, and then we'll continue or to 70 milligram, but the maintenance is 70 milligram.
Is migraine an hereditary disease?
Yes, it could be genetic, environmental, and many studies showed it is related, yes.
And headache can occur due to stress. So it's as Dr. Rudy mentioned in his session, one of the migraine trigger is stress. And as you know, in a student life, stress is a major component. So should student take any preventative measure to avoid migraine?
Usually for students, students, they are still young age. Stress that induce for them migraine, most of the cases, they are tension headache more than migraine attacks. For that reason, we have to take into consideration the correct diagnosis. And usually, I always advise for magnesium. With a high doses magnesium, it is very effective. And between brackets, magnesium, when we want to give magnesium, it is not related for the magnesium level in the blood because it is intracellular depletion of magnesium. So, many, they ask if the magnesium blood level is normal. Do we give magnesium? Yes, we give because it is intracellular depletion of magnesium for that reason.
So probably we should advise all our students that are listening to us just to have some lifestyle modification, good sleep,
Exactly.
have naps, avoid long hours of reading, avoid the screens. So all these that can also trigger migraine rather than taking medication. And if they want to take something, so as you recommended, it will be magnesium supplementation. And our
Excellent
final
point, Maya.
Yeah.
Really, just for this point, lifestyle modification is very, very important. I usually give education for my patient for their lifestyle modification, and I encourage all physicians also to ask and to insist on this point. Okay.
Yeah, it's a major component actually in
Yes.
migraine management. And a final question for you. Do you think that cognitive behavioral therapy, which is one of the kind of this psychotherapy, has a role in migraine treatment?
Usually, I have read about these studies. They showed very good outcome. Plus, if, as I said, we have the mild, moderate, or severe. Maybe I will prescribe some lifestyle modification with this behavioral therapies. If it is mild, with doses of acute treatment. But for the severe cases, it might help. But the main is the preventive treatment.
Yeah, not alone.
But also we advise for such cases. Yes.
Thank you, Dr. Rami, also for accepting our invitation despite your busy schedule and long clinic hour. It's always our pleasure to have you. And finally, ختامها مسك, as we said, with our last speaker for tonight, our great biostatistician, Dr. Hani Dimasi, who will teach us the basics of biostatistic. Believe me, he taught me like a few years ago, and I learned very well from him. So hope you will benefit from his lecture today. Dr. Dimasi is currently an associate professor of biostatistics at the Lebanese American University since 2012, with a PhD in biostatistics and an MPH in epidemiology. Dr. Dimasi taught in multiple disciplines: nursing, pharmacy, biology, medicines, at different levels and in different setups. He also provided researcher in a variety of health-related fields with statistical as well as methodological and research design support. And in the recent years, Dr. Dimasi has contributed in a number of publications related to access to health service among refugees, nutrition, oral health, and pharmacy work environment. It's always our pleasure to host you, Dr. Dimasi. The floor is yours.
Thank you, Maya. Thank you so much. You can hear me fine?
Yeah, we can hear you.
So I will have, I'm going to share my screen. Okay.
Sure.
Yeah. No. Okay. Can you see my screen fine?
Yeah, just go into full mode. Yeah.
Yeah. All right. So thank you for your nice introduction. I'm happy to be here today. Specifically that the topic is one that is maybe easy and hard, basic statistics. You know, it sounds easy, but at the same time, what should we say about basic statistics? And I personally, I'm a person that likes to make things simple because I believe that in simplicity, we can achieve a lot, specifically in statistics, because many times people fear, or maybe they feel that statistic is something that is hard or difficult. And I would like to maybe convince you otherwise by making things very simple. So my presentation is going to be very simple. I'm going to talk about things in a very simplistic way. Hopefully that will be something that you will appreciate. So what is statistics all about? For me, the core of why statistics and why do we use statistics come from the fact that in all research, basically, we're dealing with samples. We're not dealing with populations. If we were working with populations, then we did not have to worry about testing hypothesis. We would not have to worry about p-value because we would have the entire population in front of us, and we would not just be looking at a sample. See, when you're dealing with a sample, you're not looking at everybody. Rather, you're looking at a subgroup of the everybody. But there is no way to do around it. I mean, we need to do that. To understand what is happening in a population, we need to get a sample from that population. And the population could be, all patients that have migraine, or all patients that are depressed, or all patients that have diabetes, or any kind of a definition that you put for a population. Most of the time, we cannot look at the entire population for many reasons. It could be not feasible. We don't have resources. We cannot do it. We don't have the time. So we revert back to taking a sample. Is that a problem? No, it's not a problem. It actually helps us a lot because it's something that is feasible. It's under our control. It gives us a sneak peek of what is happening in a sample, provided that the sample is done appropriately. And very importantly, it gives us accurate information, meaning that we can actually use what we see in the sample to learn about what is happening in the population. But let's revisit this idea for a second. So in my next slide, I want to illustrate the idea of a population using jars. Let's suppose this is the population, and let's suppose that we know that these populations actually are made of everything blue in the blue jar and everything is yellow in the yellow jar. Well, if this is the scenario, then if I were to take a sample from these populations, then I wouldn't have a problem at all, because the sample would 100% represent what is in the population, for the simple reason that there is no variability. You know, everybody is the same. Everybody is exactly yellow, or all the pebbles are yellow, all the pebbles are blue. So whether I take 1 or I take 10 or I take 15, you know, once I look at them and they're yellow, I know that the jar is filled with yellow pebbles. That would be perfect. But we know that that's not what happens. What happens is that we are more likely working in a scenario like this one, where you have a jar that's filled with many colors. And then when you take a sample out of this jar, you're always wondering, is my sample representing everything in the population? So like here, I have an example. Did all the colors included in the jar appear in my sample? And if you look closely, you may see that maybe not all the colors in the jar are appearing in the sample. Maybe we don't have red, or if we do, we can't see it actually. The other question that you may ask yourself is, okay, well, obviously I have a variety of colors appearing in my sample, but is this distribution that I'm seeing in my sample the same that is in the population, or is it different? So this is the kind of question we ask when we're dealing with research. We're dealing with a sample, and we're always wondering how much this sample is giving us an exact idea of what is happening in the population. Now, over here, you can see the population and you can see the sample, so that's easy. But in reality, what happened is something more like this. You have your sample in front of you, but you don't see the population. You have no idea what's the population like. So you ask yourself, based on what I have in my sample, what is happening in the population? Of course, you can say, well, I know for sure that I have the blue, the orange, the yellow, the green, the red, because I've seen them in my population. But is there a possibility that maybe there are some colors that I didn't see and they're there in the jar? Is the distribution of the colors I'm seeing in my sample exactly what is happening in the jar, or is it something going on? So usually you ask yourself, well, how do I deal with this problem? Obviously, the answer here is that one, is how do you take your sample? And therefore, the idea of making sure that your sample is random, meaning you're not picking and choosing who's participating in your study. Mind you, this is not always feasible. Many clinical trials, we end up, recruiting participants through the physicians, and the physicians have to recruit the participants by making them accept to come. But is that a big problem? Well, it could be a problem or not, depending on the situation and on the study we're doing. Another issue that you can do, or something else that you can do beside how you get the sample and making sure that your sample is random and everybody gets a chance to be part of your sample, is how large your sample is going to be. So you want to make sure that you have a big enough of a sample that allows all kind of colors to appear in your sample. And there are techniques, there are ways we can deal with that. We can figure out, there are formulas that tell us how big my sample has to be for me to have a good confidence in my sample. So continuing with the same idea, if you see these two samples, I'm making it very simple, black and white. And I'm hoping that you can see that these two different samples are not exactly the same. Maybe one of them you have more white than black. The other one, maybe you have more black than white. And always the question when we see differences in samples, are these two coming from the same jar, which is possible, or are they coming from two different jars? And that's the setup we actually have many times in the research. Many times in research, we have a group that is taking drug A, the other group is taking drug B, and you're seeing differences in the two samples. And you're wondering, is it because I'm seeing a difference because these are only samples and the nature of samples is that they give you different results? Or is it because they're actually coming from a real difference that exists in the population? So how do we deal with that? What do we do to be able to answer that question? Well, fortunately, we found a way to solve that problem in statistics. And that comes into something called probability. We can ask the question, what is the probability that actually these two samples are coming from the same population, are coming from the same jar? So that would be what we call in research your null hypothesis. Your null hypothesis is always going to be they're coming from the same population. There is no difference. There is no association. Drug A and drug B are exactly the same. Whether the patient is treated or not treated, it doesn't make a difference. It's the same. So always our starting point is to say, let's assume that they're coming from the same population. And then next question is, well, if this is the case, what is the probability of observing this much of a difference in the sample if that's what's true? So that's actually how testing hypothesis. This is basically how all statistics works. You start with making an assumption that what we're seeing in a sample, of these two different or three or four samples, actually they're coming from the same jar. There is no difference. And you calculate the probability. When you calculate the probability of them coming from the same jar, well, this is your p-value actually. This is what we call in research the p-value. It's the probability that what you observed in a sample is only due to chance. It's only coming from, these two samples are coming from the same jars. And obviously, if the probability is large, meaning that there is a high chance that these two groups that you observed a minute ago, there is a high chance that they're coming from the same jar, then we say, well, we have no evidence to argue against that, and we're going to go with the conclusion that they are coming from the same jar. The other thing that may happen is that the probability may be very small, meaning that, well, if there's only one jar and one jar only, and you're seeing two different samples, that much of a difference, that shouldn't happen. And that's where it leads us to what we call statistical significance, rejecting the null, and declaring that there is a difference. Well, how does that work? I'm going to give you a very, very simple illustration, and I'm going to use that example to do a follow-up. So I'm starting with a population that is tiny, only 5 balls or pebbles in my jar. 2 of them are black and 3 of them are red. I named them because I want to show you, how you can get, what are all the possible samples you can get from this 5-pebble jar. And if my sample is also very tiny, let's say I'm only taking 2 at a time, well, there are 10 different ways of me getting a sample. So I can take the A and the B, the A and the C, the A, and you can see how it goes all the way down to the D and the E. And I illustrated for you the colors. So there's only one way I can get 2 black. There are 5 ways, if I'm not mistaken, to get 1 black, or maybe more, 6, I'm sorry. 6 ways I can get 1 black and 1 red. And there are 3 ways I can get both to be red. And doing so, I can draw this nice chart, which we call the probability distribution of observing different samples. And you can see that the highest probability coming from this jar is for me to see half and half, okay? Half black, half red. The next probability is for me to see all red, and there is a tiny probability for me to see all black. So having said that, I can use this information, hypothetical information, what can happen hypothetically. Obviously, we don't take all different samples. This will be a loss of time and not feasible. But the concept helps us. The concepts help us in developing a probability distributions. And then we can ask the question of what is the probability that my 2 samples I'm coming from the same jar. So let's continue, and let me give you another illustration. Let's suppose that you have a jar and you have no idea what's in the jar. And let's suppose you take 2 samples. Each is made of 10 pebbles. And in the first, you get 5 red, 5 black. The other one, you get 8 red, 2 blacks. And you're not sure if these 2 are coming from the same jar or not, okay? But these are your 2 samples. And you want to ask the question, well, if this is what I'm seeing in my samples, if I'm getting a sample 5-5 and a sample 8-2, what is the probability that they're actually coming from the same jar? Well, there is a very nice formula that we can use, and we can calculate that probability. And if I were to tell you that the probability that these 2 samples actually came from the same jar is 30%, there is 30% chance that these 2 samples came from one unique jar, then that tells you that actually there is a lot of probability. There's the likelihood of these 2 samples actually coming from the same population is very large. That would be my p-value. My p-value here is 0.3, meaning that if I go back to my null hypothesis that says there is no difference, these 2 samples are coming from one and unique population, I cannot reject that, and I have to come down to the conclusion that it seems that these 2 samples are coming from the same jar. On the other hand, if I have 2 other samples, now this time I have in the first sample 8 black and 2 red, and the second sample I have 2 black and 8 red. I can ask the same question. What is the probability that these 2 samples are coming from one unique jar? Well, it happens that the probability of these 2 coming from the same jar is only 2%. There's only 2% chance that these 2 samples are coming from the same jar. And therefore you say, well, this probability is too small, and therefore I don't think they're coming from the same jar. I'm going to reject the null hypothesis. You may ask, well, where do I start drawing the line between a probability that seems to be, large enough for me to say, well, I'm not going to argue against the one jar hypothesis, versus where I can start saying, well, no, I don't think they're coming from the same jar. The traditional is the 5%. So you may have heard of the p-value being statistically significant if it's less than the 5%. Well, that's where the 5% is coming from. Any probability that is less than 5% means that we don't believe that they're coming from the same population, and therefore we conclude that group 1, sample 1, is coming from one population, and group 2, sample 2, is coming from a different population. And we declare that the difference we observed is statistically significant. Okay, well, that's great. This is an example where I'm comparing, samples with 8 and 10 and 10 Could that be, generalized to a larger scenario? The answer is definitely yes. We can compare two means. So I have a group 1 with mean 1 and a group 2 with mean 1. So for example, you would be testing what's the, let's say, quality of life among a patient taking treatment versus quality of life among patient not taking treatment. And you ask yourself, well, do I have reasons to believe that what I'm observing in a sample tells me that actually there is a difference in the population? Remember, we don't know what is happening in the population. But based on this probability that I would calculate, I can answer this question. And the answer, for example, if you're comparing the two group, is going to be your independent t-test, if you're familiar with this term. Or it could be a pair t-test. I mean, depending on the scenario, if there's some sort of a matching, well, allow. What if there are more than 2 groups, 3 groups, 4 groups? Well, here we start using something called the analysis of variance. And again, the analysis of variance will allow us to declare if these 3 or 4 or 5 groups are coming from the same population, or are they coming from different populations? Same idea. And what if I'm interested in comparing percentages? Or what if I'm interested in comparing rates, ratios? Well, there are statistical techniques that can help you answer that question. The idea here is that it doesn't matter what are you comparing. Your ultimate goal is to look at this probability that you calculated. Is this probability small or is it large? So if it's small, it means that the assumption that all these groups are coming from one unique population is rejected. And we're going to say, no, no, no. Every one of these is coming from a different population, and therefore there is difference in the population, which most of the time gets researchers excited. I mean, think about a drug company. They're making a medication and they want to show that their new medication is actually better than the old one. Well, they want to be able to say that our patients are doing better than those taking the old drug, and they cannot take everybody. Obviously, I mean, we cannot do a study on all the population. Therefore, they get a sample and they observe the sample taking their medication, and another where they're going to measure using the traditional medication, and they're going to compare how much of a difference there's between the two. And the key is going to be this probability, this p-value. If this p-value is large, I cannot say they're different, and then my medication is as good as the old medication. However, if the p-value is small, then I can start arguing that my medication is different from the old medication, and hopefully my medication is better. Okay, so that concludes part 1 of the basic statistics, understanding the process and what is the p-value and how does it work, and the idea of I'm working in a sample, I'm not working in a population. The next thing I want to know is, well, okay, fine. So what are the things I can calculate, or let me say, estimate in my sample? Because remember, we have to always remember what we're calculating in a sample is only an estimate of what is happening in the population, okay? Because it's just a sample. There are a number of things that we can calculate, and I'm going to give you like a quick overview of a few of them, just, see if you feel comfortable with these values as you see them maybe in the future. So the first thing I'm going to talk about is the mean, and to illustrate the meaning of the mean, I'm going to say that I have a sample of 7 individuals, and in every individual, I've calculated their stress score. And the stress score, let's say, can go from 0 all the way up to 12. And so if you think about it, what does it mean, a stress of score of 2? It means that person is above the 0 by 2 values. And that's why I'm drawing these bars. I'm trying to show you that the value of 2 means that, that person is above the 0 by 2 points. Similarly, for a stress score of 9, for patient number 2, it's 9 points. Well, a mean is nothing but trying to find an average, a place where how far did you have to go above the 0 that average out everybody. Another way, a mean is you're going to look at all the values that are below the mean, all the values above the mean, and if you line them up, they're going to be exactly equal. Sometimes I say a mean is like a center of gravity. That's the point where, you know, the distances below it and the distances above it, they cancel each other. That's what the mean is. And it has a very nice arithmetic value. Well, is the mean the only thing we can calculate? No, you can calculate something else, which is called the median. But to be calculate the median, first you have to order the values, lowest to highest. The same concept, you're going to have to find the middle point, but this time you're not interested of the distances. You're more interested in how many values are before and how many values are after. So the median in this example is patient number 4, which has a median value of 7. And I want you to notice how the mean and the median are not equal. They don't have to be equal. So what does it mean the mean is 7? It means that half of the sample is below it and half of the sample is above it. It does not mean that the distance from that median going down and the distance of the median going up are equal. They're not. I know that for a fact because the mean, which is what actually is that value, is 5.5. So the median doesn't really care about what were the value below it and what were the value above it. The median is just the value that is going to say to you, I have half of the sample before me and have half of the sample after me. Well, when do we use what? The rule of thumb, if the values you're dealing with have a nice symmetrical distribution, then we go with the mean. The mean is very nice. However, if you have a skewed distribution, skewed meaning that you have very large value, either very high or very small value that are very low, in this scenario, we were more likely to use the median. Okay, well, what about the standard deviation? Well, remember when I was talking about the mean and having values, you know, coming right in the middle and you have values above it and below it? Well, the standard deviation is going to also look at these distances, how far away the values are above it and how far away the values are below it. And we're going to take all these values and we're going to kind of calculate an average of these distances. Okay? It's not exactly that, but it's kind of served the idea. So if you want to know what a standard deviation means, you know, like standard deviations, so deviations of what? The deviations are the deviations of each value from that mean, from that central point. And how average they are away from that is your standard deviation. Meaning the more you have a variety in your sample, the larger is going to be your standard deviation. And the less variety you have in your sample, the more homogeneous your sample is, then the lower is going to be your standard deviation. For example, if everybody's got a score of 8, well, the average is going to be 8, obviously, but the standard deviation is going to be 0 because there is no variability. And we are very keen about variability. We like variability because it gives us an idea of how good our estimate is. And I'm going to come back to that in a second. Okay, well, what if I'm dealing with is not something that you can calculate in average? What if I'm dealing with something that is either positive or negative, you know, present or absent? Well, there are a number of things that you can calculate. So here I'm showing you an example of 10 cells. 4 of them are blue, 6 of them are gray. A proportion is just, you know, looking at how many are blue and dividing by the total number of cells, which is 0.4. It's fine. I mean, we know that. That's nothing fancy. And you probably know that if you take that and you multiply it by 100, you get a percentage, which in this case is 40%. Yeah. But sometimes we start talking about this as being in a risk, not as a proportion. You can start talking about this being a risk if the design allows it. If your design is prospective in nature. For example, if I want to talk about what is this risk of suicide attempts, well, you have to start with a group of people. None of them had a suicide attempt, and you start doing a follow-up with them over time. And as time is passing, you will have new people that would have suicide attempts. Well, these are going to be your numerator, and everybody is going to be your denominator. It's calculated the exact same way, but the interpretation is different. So you're going to say the risk is 0.2%, for example. Okay, it's calculated that proportion, but it's interpreted differently. What about a rate? Well, again, it's kind of the same thing. You're doing the same calculation. However, you have two things that you have to account for. One, you have to give a period of time. So typically a rate is over a year of time. Second, usually a rate is going to be a small value. Therefore, most of the time we multiply it by a constant to make it more easy to read. So for example, if I say the suicide attempt are 12 in 10,000 over a year period of time, then the answer is going to be 0.00112. We don't like these numbers. So what we do, we multiply by 1,000, and then we say the rate of suicide is 1.2 per 1,000 per year. So again, your design has to allow you to calculate these things. All right, what about incidence? Same thing, it's still a proportion, but now you're dividing by those that are at risk. Yani, if I'm talking about the incidence of, let's say, prostate cancer, I cannot divide by everybody. I have to divide by men only. If I want to talk about the risk of medication abuse, then I have to only divide by those at risk, yani those that are actually using the medication. So you can see how like one number, one calculation can have multiple interpretation and multiple use, provided that your study design allows it. Last, I want to talk about odds. Odds is not something that we talk a lot about. And odds is basically, you know the proportion I said blue over the total? Odds is blue over gray, not over the total. So what used to be 4 over 10 is going to be 4 over 6, and I'm going to get a different value. It's very important to note that, because in research, you're going to see people using odds, but you have to remember that an odd is not a proportion. So an odds vary between 0 and all the way up to, thousands and thousands. However, a proportion only is captured between 0 and 1. ما في proportion 1.2. ما في percentage 120%. Percentage is 0 to 100%. Proportion is 0 to 1. But an odd can go from 0 to 5 to 16 to 20. Because an odd of 1 is equivalent to 50%. An odd that is less than 1 is equivalent for a percentage less than 50%, and an odd more than 1 is equivalent to a percentage above 50%. Okay, then last thing we can do with these, the proportions and the odds, we can actually do a ratio. Why do we do a ratio? Well, remember the idea, we want to compare groups, right? I have group 1 and group 2. This group is giving me a proportion. This group is giving me a proportion, and I want to compare them. You can compare them calculating a difference. You can do that. But many times researchers like to do something else. They like to do a ratio. Put the proportion in group 1 over the proportion of group 2. Obviously, if they were equal, you would get 1. So 1 is the value that indicates no difference. So here's an example. If the risk of, let's say, addiction is 0.4 in group 1, the risk in addiction is 0.8 in group 2. If you do the ratio of group 2 over group 1, you can calculate something called RR, relative risk, or sometimes people call it the risk ratio. And here it will be 2, meaning the risk in group 2 is double the risk in group 1. It's 2 times larger. And here I'm saying risk because the study has to allow me to calculate the risk. What if the study does not allow to calculate me a risk? It only allows me to calculate a prevalence. Well, same thing, same calculation, 0.4 in the first, 0.8 in the second. Now the ratio is called prevalence ratio. And here 2. Now this 2, I do not interpret it as the risk being the double. So like if this is addiction, I don't say that getting addicted to drug 2 is twice as much as getting addicted to drug 1. No, I say the prevalence of addiction in group 2 is twice as much as the prevalence of addiction in group 1. And there is a whole lot of difference in what do they mean, these two things, but they're calculated the same way. A third example is incidence. So if my incidence in group 1 is 4 per 1,000 per year, incidence in group 2 is 8 per 1,000 per year, I can calculate something called incidence rate ratio. And here again, I'm giving an example of 2. And therefore, the interpretation would be the incidence rate in group 2 is double that of group 1. What if I'm working with rate? Same idea. Here, for example, I'm giving something called the annualized rate ratio. So here it's 2 again, meaning that the rate is double 1 versus the 2. But notice how, if I do the odds, remember what I had 4 over 10, which is 40%, the odds is 0.67. The odd of 80% gives me an odd of 4. And notice how the odds ratio here is 6 times larger. So the interpretation has to be here, not that the risk is double, not that the prevalence is double, the odds is 6 times larger. And one thing I keep reminding people, and you have to be cognizant about that, is that odds tend to be inflated because of their nature. Remember, I said an odd can grow very large. So an odd can grow to 6 and 8 and 15 odds ratio. Okay, and we're not surprised about that because that's the nature of it. Versus a relative risk, you don't see relative risk more than 3 usually. Odds ratio, you see 8, 9, 10. That's perfectly normal. But for all of those, the value of 1 indicates no difference. And therefore, when you're testing your hypothesis, when you're checking if your relative risk or if your odds ratio is statistically significant, you're trying to see if it's statistically different than 1. So how do I tell if it's statistically different than 1? There's 2 things you can do. 1, you can look at the p-value, as I explained in the first part of the study, of my presentation, I'm sorry. Or 2, you can do something called a confidence interval. So what is a confidence interval? A confidence interval is a calculation done that gives you an idea of how accurate is your estimate. Okay, remember, we're working with estimates, meaning we're working with samples, meaning the values that we have are not the true values. These are only estimates. And we know by nature of things, estimates tend to change sample to sample. So in my sample, how confident I am in my estimate? Well, you take that estimate and you build around it something called a confidence interval. And that tells you if it's statistically significant or not. How? Well, let me show you on the next slide. This is a slide I borrowed from a previous presentation. And all you're seeing here in different colors, these are rate ratios, the point right in the middle. And as they're going up and down, these side-by-side bars, this is the representation of their confidence interval. And you can see that there is a red line right at the 1, because as we said, the 1 is the indication of no difference. If your confidence interval crosses this value 1, then there is no statistical significance. If your confidence interval does not cross the 1, either if you're on the left side or on the right side, then your odds ratio or weight ratio or whatever ratio you're doing will be statistically significant. And we take 2 messages out of confidence interval. 1, if it crosses this line, this red line, then it tells us if it's statistically significant or not. 2, how narrow and how wide it is. We like the confidence intervals to be narrow because that means our estimation is more precise. Then I feel more comfortable with my precision. And there are things you can do, to work on your confidence, how much confident you want to be, your sample size, etc. But I'm not going to go over this in this presentation because, this is basic statistics. I'm done, actually. I hope I'm coming to the end of my presentation. I'd like to really thank Maya for inviting me, IVPN, NeuroPsychiatry, and Novartis for the opportunity to talking to such a wonderful audience as all of you. I hope my presentation gave you, a brief idea of what basic statistics are, maybe a different view, hopefully like a new way to look at them. And I'm ready if you have any questions.
Thank you, Dr. Dimasi, for this excellent presentation. Actually, there are some questions I can see. So in the slide where you mentioned the median.
Yeah.
So Dr. Sahar is asking why the median is 7 and not 4.
Yeah, I mean, I tried to make that point. Maybe I was very fast. So the nature of the median is that the value that comes in the middle once you order your values, and it doesn't really depend on what were the values before it and what were the values after it. So the median is just the value that comes in the middle, whereas the mean, this is the value that really tells you the equidistance between all of them. So here it was not 4 because the patient number is 4. If you remember, I'm going to share again. Do you mind, Maya, if I share again?
Yeah, sure. You can share, Dr. Your screen.
I think
Hassan,
I
please
have.
allow Dr. Dimasi to share. Yeah.
I think I have a better. I have now a better idea of her question. So I think you were looking at 4 here, and I apologize. Maybe I should not call them 1, 2, 3, 4, 5, 6, 7. Maybe I should have called them, A, B, C, D, E, F. These 1, 2, 3 are not the values. The value is how far up is the bar. You should look at the y-axis. So I think now I understand your question. Yeah. So the median is 7 because how far up, this is the actual value. So if you ignore the 1 to 7 on both ends, if you call them just, different people, A to B or A, C, D, F, G, then it will be clearer.
Another, Another question. So Ahmad is asking that in the midst of the scientific research, whether clinical or preclinical, we can see that researchers are always presenting figure that looks more representable. For example, they don't be honest in representing the standard deviation or the errors of the mean. So they use the factors that suit the figure without respecting the accuracy for the research. And knowing that in the legend part, they don't also add the real value corresponding to the represented figure. Also, most of the reviewers don't ask for the raw data of the statistical analysis. Is there any way to know if these data are real?
Thank you. I think, he started with a comment more than a question, and his comment is very welcome. I know that more and more research journals are requesting a couple of things. One of the things they request for a repository for your data. They ask you to make your data available, open access for everybody who wants to review it. Another thing is, if you're keen, if you're fun about data, if you like it, there's always way you can catch them. You cannot make up there 100%. You will always make a mistake, and we can capture that. I'm going to give you an example. Not that we are fabricating data, but sometimes there is a mistake. It could be a mistake in selecting the appropriate subgroups, or it could be a mistake in data entry, or there is a mistake in coding, which happens. We capture these things when it comes to running the analysis. You will have a standard deviation that looks weird, or you may have numbers that are not adding up. And the more if you're fond of these things, the more you spend time looking at, the more you develop the skills of catching these things, and you will be able to catch them. And I like to trust the peer review process that happens in reputable journal. For most of the part, I think they do a good job at making sure that the data presented is accurate. Although you would be surprised, sometimes there is always errors that make it to the publications. And one thing we do, Damon, always is before we do any analysis, we make sure to clean the data, to make sure that we clean the data. Last thing, more and more reviewers are requesting the assumptions to be checked for the statistical analysis, something that I did not discuss. Maybe one time we can do a presentation. The normality, the quality of variance. They'll ask you, did you check that? Did you do that? Can you share with us what were the results? Just to make sure that what you're presenting is accurate.
Thank you, Dr. Dimasi, for accepting our invitation. And
thank you for inviting me.
More sessions with you, so we can benefit from your expertise in the fields of statistics. And with Dr. Dimasi enriching presentation, our second NeuroSTAT webinar comes to its end. I would like to thank again our esteemed speaker and thank Novartis for sponsoring this activity. And of course, the big thank you goes for you, our attendees, for staying with us until the end of the webinar. I would like to remind you that you will receive your certificate of attendance by email within 1 week from today. And if you missed any part of this webinar or you would like to revisit the lecture, you can always check our IVPN NeuroPsychiatry library, where we post all the recording within 1 week from today. You can access all today's presentation, and also you can review all our previous educational activities. Follow us on our social media platform and stay tuned for more NeuroSTAT series and for our next educational activity, which is scheduled on May 18, and which will bring you all the update in the management of depression, schizophrenia, and multiple sclerosis. Until we meet again, stay safe and have a good night.